Gentlemen, what we've heard so far, are you satisfied with the session this morning?
Yes, I think it's great that, through this activity we are bringing this important topic onto the agenda. But not just that, it's also that I think it's becoming very clear that there are a lot of things that we can do by working together. Of course, there are some big challenges. This is not the easiest of issues to address because it's almost an invisible issue, if I could call it that way. Too many people suffer in silence on this. It's difficult to measure, and our modern approach to health is about measurement. So really this adds another challenge. But I think there are clear ways in which we can address this. One of the indispensable things we have to do is really to ensure that we capture the expertise and the experience of those who know most about pain, and that's the patients, and of course those who are close to them. They know a great deal, and when we come to discussing, for example, how we can fine-tune and optimize our research efforts, how we can ensure that we can actually better describe outcomes, that perspective is absolutely essential. So really I think that this is a good event for me.
That means because we have so many advocates for the patients, and I'm always looking at you, Jane, because we had a talk, and others, of course, and you raise your hands, that we also give them the possibility to ask questions, to raise their voice, not just talk about them, but talk together with them about this. Thank you, Joop, for joining us. I think this is crucial because you just said, who knows better than the patients themselves? Chris.
Thank you. Thank you, Martin, because actually you picked up our tagline from 2001, don't suffer in silence.
Right.
And EFIC did this. This is what we said to the patients. You mustn't just suffer. You must go and tell people about your pain and get something done about it. We still have this issue with general practitioners saying to their patients, what do you expect? You're 70, you've got pain in your joints. I'm 70 this year. So I want these GPs to focus on things. And I think one of the very important things that comes out of this, and we need to concentrate on, is the cost of pain to society. We know this. This is 34 billion a year in the EU. We can't afford that, can we? And the point is, I think by sharing best practice and forwarding that throughout Europe, we will actually save the EU money. And I think that's a very important thing for you to take home and the MEPs to take home. We're not coming here asking for a blank check for this. We're actually going to share good practice and we're going to save you money.
Sometimes,
and we're going to help your patients.
Well, as you said, sometimes hard figures are necessary to proceed and to give the policymakers the perspective. So it's not just about pain. It's really a massive impact. Everybody has to share, actually. Joop.
Well, if you're talking about the impact of pain and what is the best practice and how is it measured in money, it's very nice, of course. But still, somewhere in Austria or somewhere in Romania is sitting with pain at home, having no job, having lost his relationships, having lost so many things in his life. So if we are talking about best practices, we have to talk about best practices which are best practices for the patients and not which are best practices for the doctors. I'm sorry to say that, but best practices for the patients is always the best outcome for every treatment. And I think that would be the main thing we have to give on the platform as well. So patient associations who are here at the moment, please send in your best practices and put them on the platform so everyone will know what is the best way to treat patients. I think that would be very important. And from that, you can figure out all the money questions and all that. But improving their quality of life would be the ultimate goal of having that platform.
Martin, you mentioned earlier on that we need to generate more evidence for policymakers and decision makers if we want them to focus on this particular topic. Is there something specific you think is lacking at the moment in terms of that evidence base that we as a multi-stakeholder platform could work on and provide to you in the Commission that would help you to advance your work?
Yes, I mean, there's the old saying that what is not measured does not get done. And policy making has to be evidence-based. Now, this is a big challenge. Why? Because first of all, the way we've been collecting evidence historically has been largely statistical. You do surveys, you spend a number of years validating, elaborating, and then you come up with a set of numbers. And sometimes that takes so long it becomes historical data. And it doesn't really capture the real issues sometimes. Now, this doesn't have to be the only way. There's a lot of, and this is why I mentioned earlier, there's a lot of untapped sources of evidence. First of all, the patients themselves and those close to the patients. If you want to talk about outcomes, they can tell you a great deal about outcomes that are successful or less successful. And that's very useful information. For example, if you're doing research for the development of new technologies, you need to have that feedback. A doctor who would like to optimize treatment, and all doctors do, needs to have that information. The second challenge is how to move more towards real world and real time information. Now, this is no longer a pipe dream. Technology makes this possible.
Big data.
Big data, but also use of everyday devices. Why not have an app that I could actually give my feedback to my doctor and to the health system in general about my experience with this treatment? That can be done in real time as we speak, from the comfort of your own home and in your own private setting. That's something that can be done. Why isn't it done? Because it needs to be organized, it needs to be standardized, we need to incentivize it. Now, just imagine if we had that, what that would mean to really help direct research and efforts to really improve outcomes. Because you would get from the source what the positive outcome should be. And also, it's all about also using things like big data, but also, health systems. If you go for a 15-minute consultation with your GP, the moment you walk into that clinic, you start generating data. Measurements are taken all the time. How much of that is used to improve practice, to kind of fine-tune the approach? Very little. The hospitals, they generate prodigious amounts of data. I know of very few sectors that generate so much data. It's not used systematically. And then we have big challenges because we have to invest billions to try and understand, what works and what doesn't work. I'm simplifying here, but this is really the heart of the problem. And one of the things we want to do in the context of our digitalization and the digital single market, and also the communication we will issue towards the end of this year on digital health, will be precisely how we can turn health data into a resource. Of course, fully respecting all the privacy issues and data protection. But you don't need to know very often the names of the individuals. You can anonymize that data, but it's still very, very useful. And this will translate into a huge benefit.
And what can we do to help you with that? Is it an education process that we need to tell patients in Europe, what data protection means, how this would work? Is it something we need to be devising in terms of helping you create those technologies? What exactly is it that we can contribute?
Well, first of all, certainly the patient's perspective. We need to understand what issues are sensitive to them and what are their concerns. But also, even the professionals. How well informed are doctors about data protection? This has led to the health sector. Health sector, I find it a bit of a paradox. I'm not a doctor by profession. I studied chemistry. So I come from a bit of a different background, even if it's a parallel background. But I've always been intrigued by one simple fact. On the one hand, the medical sector uses some of the most advanced technology that you can think of. So doctors use very sophisticated tools without batting an eyelid. They use them. And then they go to pen and paper, to write a prescription. Only 1/4 of doctor-to-doctor referrals are done electronically in the EU. E-prescriptions are a rarity in many countries. You have to go with a piece of paper with all the risk of mistakes, impossibility to manage polypharmacy, for example. Patients with chronic pain are often taking multiple medications. Now, how do you reconcile that? Sometimes they are prescribed by different doctors. How is the pharmacist supposed to help with optimizing or advising on the correct use of the pharmaceuticals. So, I know of no other sector that can go from, a sophisticated scanner to pen and paper in an instant like this, and we have to change that.
This is a good reason for Britain to stay in the EU then, because actually we're very good at that. All GP prescriptions are done electronically on a computer, which tells the GP about the side effects and can be communicated in that way. So, hopefully after last night, we may be just edging a little bit nearer. So we'll see what happens. I think some of the things that you've talked about are very important. And EFIC has set up task forces on best practice. So we have 6 now. One is reported on opioids. We have another one on cannabinoids, which is really important at the moment and important for patients. That's what patients are asking us when they come in to see us. What about these cannabinoids? Well, it's not all one way with them. There are pitfalls as well, but there are benefits. And that's something that we do, and again, to share best practice throughout Europe. And that's a really important thing. And of course, we have our exam, and that's to try and teach doctors about best practice and then get them to get a certification. So what we hope we'll see in the future in Europe is doctors treating pain who have an exam, a diploma in pain medicine.
Which is education, another
Which
key.
is education.
I mean, best practice without education doesn't mean anything.
Yeah, but this is why we hope we can actually deliver the best practice, because it's not just about producing papers, is about how do we deliver that. So we think by making doctors better educated, which came out of SIP in 2014, if we can push that throughout Europe, then the patients are going to get a much better deal, because they're dealing with doctors who actually know what is good practice.
Well, it would be nice, and then as the patients' associations could also be involved in that education program for the doctors. Because the patients can also learn, the doctors, what good therapies and best practices are. So that would be nice to involve them as well.
This is why we have patients in our schools. And Pete Moore talks in our schools about self-management. He is in our Klagenfurt school.
Martin, I think, had a point.
I think this is an important issue that you just touched upon, because one of the things I think which many professions need to address is the issue of the soft skills. How do you communicate with patients? In the past, doctors used to be very good at this because they had to extract a lot of information from the patient. So even a handshake, they could get a feel, or even the way the patient. Now, with the growth of technology, I often joke with my GP, you spend more time looking at the instrument than at me. But that's the reality. But also, let's not forget the role of the other professions. Nurses, for example, have a huge role to play. Medicine is becoming more and more multidisciplinary. So the GP, the specialist, but also the nurse, the pharmacist, the physiotherapist, the psychologist, they all have a role to play. And this is why, for example, if you don't have a single electronic health record that can be accessed by all of the actors as necessary, then, you will not be able to provide this, because multidisciplinary care, if I look at my own medical file, it's probably scattered all over the place, across more than one country and I'm sure it's true for many of us, but also among different healthcare providers. How on earth can integrated care ever happen with that kind of situation? So we need to use the tools, not for the sake of the tools themselves. I'm not obsessed with technology, but technology exists and we can use it if we know what we want to change. Let's be very clear. Health needs to undergo a transformational change. We cannot continue to deliver. We've been talking about, we have to move away from hospital-based care to patient-based care. This has been the mantra for ages. It hasn't happened yet in many cases, but for things such as pain and for chronic disease in general, in most cases, hospitals are not very useful, because they are designed to deal with the acute manifestations, certainly not with prevention, certainly not with early intervention, and certainly not with long-term management. So we need to go towards integrated care, we need to support people in their own homes, in their own communities, and you need to make sure that there are enough sources of information close to the patient as possible.
I would like to take the opportunity. Is someone in the audience who would like to ask a question? I take a microphone. Just give me one of those. Thank you. I start with Jen, and I come with you.
Is it on?
Yeah, it is on.
We've been talking.
The blue one.
Huh?
Oh no.
Is this on? We've been talking about this being a multi-stakeholder meeting, but I haven't heard anybody mentioning about health insurers being present, because where patients are concerned, while good pain treatment may be available, in today's world, in many countries, health insurance are finding every possible excuse not to reimburse that good treatment. And sometimes these excuses are utterly ridiculous. And this makes the best treatment inaccessible for a large proportion of patients, and particularly poorer patients, even the average patient. And this needs to be addressed before new treatments are researched and developed.
Thank you very much. That's actually so important that we've got a workshop on it in Copenhagen. And we've taken the decision to do that, to educate doctors and possibly patients, because we hope patients will come to the meeting, about what they do when they are deprived from treatments. And we know that this is what's happening. We produce the nice guideline on low back pain, really good guideline. It's not more expensive than the present care. In fact, it's probably less expensive. And one of the pillars is what you should do. And providers in the UK, including insurers, but also local governments, are preventing these treatments from being used. So what we want to do is teach doctors advocacy about what to do, because doctors don't do that. They don't like that. They want to say to the patient, you should have drug X or you should have treatment Y, and then do it. And then all of a sudden they get a letter from the health authority that says, you can't give that drug. And they just usually shrug and go away because they're not trained into what to do next.
Is that sort of inequality, Martin, something that an EU cooperation on health technology assessment could help solve?
Yes, I mean, the issue of inequalities is perhaps the most serious challenge Europe and indeed the world faces at the moment. It's literally tearing the political fabric apart. It's one of the reasons for that is we've taken, I would say, a very bookkeeping approach to health. We just look at the end result and forget that that end cost is the sum total of a lot of things that happen or don't happen earlier on. The health system just picks up the tab for a whole host of system failures. Now, I fully understand the logic of governments and insurance companies that want to keep costs under control. We all do, because ultimately the costs will revert back into taxes. But we cannot address costs by end-of-pipe solutions, saying, we have to cap or limit treatments. First of all, you mentioned insurance companies. Well, they should be very proactive, first of all, on prevention, and on insisting on prevention programs and early intervention programs. They should be the one really pushing hard for that. Same for ministries of finance, because if you want to reduce, we all know that the most expensive part of the health system is the hospital. So anything you do outside of a hospital is guaranteed to be cheaper. No? So that has to be the simple logic. You reinforce prevention, primary, secondary prevention, early intervention programs, integration of care, primary care, community care. And you have to make sure you are organized to do that, because the reason it doesn't happen is that, for example, we have not mobilized the full potential of the various professions. No? That doesn't happen. And then to use tools such as, for example, health technology assessment. We are working on this at European level. We also plan to have a public consultation on that, and we're doing an impact assessment at the moment to see what is the best way forward for European cooperation on health technology assessment. Health technology assessment is a scientific methodology for comparing the cost effectiveness and the results of various approaches so that you can get the most out of your investment. Health is an investment, and like any other investor, You look at what you invest and your return, and you try to optimize your return. So really, we are facing this problem, and we are creating inequalities because we are waiting too late to intervene. Intervening earlier and intervening in different ways can actually, I am convinced, and there is evidence for this, can bring down the costs remarkably.
Donna, here's another question we have to, yeah.
I want to thank you very much. In good faith, I'm saying that, because this is the best I've ever heard from DG Sanco. It seems to me that while you are trying to remain within the mandate of your purview, respectively not interfering in the health, you delegated this to the level of the national governments. You found some modalities to push the governments to take some action. I'm very grateful to that. I am a Romanian, I'm coming from the Eastern Europe. You have mentioned two things which are, to me, sound fantastic. One is the best practices, of course, and this is something which we have been discussing for years, harmonization among member states. This is a very intelligent mean, and thank you again for that. But my question comes with the profiles for all EU member states. You mentioned opportunities. Are these profiles, first of all, will they be public? Will they be reviewed from time to time? And is there a time frame? Because you are talking about, in these profiles, you will assess the situation, the current situation, and you will list also the opportunities for improvement. I assume that you also you are also giving them a time frame. Because these profiles, I have to tell you that they may be for us, for a patient's advocate, very useful tools, because we can go to our national governments and whereas until now we did not have a proof, or, it was like verba volant, now we can we can refer exactly to something which is released by the European Union. Thank you very much again.
Thank you. That is indeed the objective. First of all, the profiles, yes, will be public. We will be making all this information, not just the profiles, but also the working behind them, the data that underpins that, to make sure they are objective and that this is done with the highest possible quality. We are working with the OECD and with the WHO European Observatory for Health Systems and Policies that have very high credentials in economic and health analysis, to make sure that this is not just the Commission speaking. This will be a really factual and objective analysis using the input of the best experts we have access to. And then we will present these results to the member states. This is not the Commission passing judgment on member states. We are not there to say this member state is better than the others or worse than the others. But what we want to stimulate would be that this feeds into the national decision making, because we know that in health most decisions will be taken, and for good reason, nationally or even regionally in many cases. So how you bring that in a way which is appropriate for decision making. So really highlighting not just the issues, but also the instruments that are available, for example, at European level, or that can be achieved through member states working together to solve that problem. Now, we will do this on a regular basis. This will be a regular biannual cycle. So every 2 years, we will issue a set of country reports. And so every 2 years, we will target specific issues where we see there is a need to highlight specific aspects. Of course, we will not tell member states to change everything or ask them or to look at all issues. It will be up to them to decide what they want to change. But we would like to establish a link between what Europe is doing and the national policy making. All too often, we have made the mistake of simply spending a lot of useless time arguing whether Europe should do something or the national level should. This is not the way Europe works. It's not either or. Europe is about collaboration. So member states, governments have their strengths. the EU has different instruments. It's only by bringing them together and using the respective instruments in the best possible way that we can make an impact on these issues. So Europe is not in competition with the member states. We are there to support the member states and the regions in their work. And that's what we're doing. We're identifying the best ways to do that, and one of them is actually making sure they have the right evidence on which to base their national decisions.
Thank you, Martin. And Rolf would like to add something.
Yeah, Rolf Dieter Trede. I have an appointment with Heidelberg University in Germany. So I very much liked your presentation, all parts of it. I would like to comment on two, and then I have a question on a third part. You mentioned several times that to find out about pain, you have to ask patients, and this is highly significant. You will be happy to hear that at a recent meeting of the German medical societies, an oncologist stood up, gave a lecture that for future oncological treatments, they have to start collecting data on patient-reported outcomes. So this, I think, is very encouraging that it's working. I'm also very grateful that you used the term evidence-based policymaking. We're trying to advocate that in Germany. I will quote you on that. Now get to my topic. You advocated the use of routine data. And this is another part that I was very happy about, because the gold standard, or the proclaimed gold standard, RCTs, it's a simple calculation that there are not enough people on this planet to do all the important RCTs that we need. So we need alternative methodology. Unfortunately, the methods aren't very good. And in Germany, in the Medical Association paper, the journal, there was a paper on the current technology being not good enough, so that we should not use registry data for decision making, which based on the poor quality probably was right, but prospectively was not such a great idea. So I think it would be really great if the EU could help develop methodology. A lead that I have is probably from economics, because they don't do RCTs, they have inferential methods. And do you already have programs in place to facilitate methods development, or is it something that you can initiate and maybe ZIP can help?
Yes, we have been working precisely on a number of areas on developing the necessary methodologies. For example, in the area of HTA, we have had for many years already a collaboration called the UNETA, which is a joint action on HTA, where member state experts from the national HTA bodies have been working towards establishing a more harmonized approach, and not just developing methodologies, but also testing them. So basically doing common HTAs. They have demonstrated that it's certainly possible despite the big diversity initially in the approach. And now we are looking at identifying the factors which sometimes lead to kind of difficulty to use HTAs done in other contexts. So what are the barriers that really stop the full usage of HTAs done elsewhere? So we are looking at that, and we will look at also at the various components of the HTA. So the collection of data, the clinical assessment, the various methodologies for that, but also the socio-economic assessment. You mentioned also the registries. This is another area where I think there is a great need. We have some experience already at European level with cancer registries and rare disease registries. But I think the time has come to really have a very focused European approach towards registries. Why? Because first of all, we have the means today to collect data in more real-time, real-world data, and that can be used for many purposes. For example, we can reassess approaches periodically on the basis of real-world data. This is something which would complement the original clinical trial. We could check to see whether the results actually were what was expected. And if not, how that treatment could be optimized. But even professionals could, with the right front end, be able to access and interrogate this data to really identify, compare, for example, different approaches, because we have different medical traditions in Europe. This is a strength, because you can actually compare different approaches and really optimize treatment on that basis. But of course, this can only happen if there is standardization, because you cannot compare apples and pears. You have to be able to identify, and one of the key issues in registries, for example, is how do you define the outcomes? What are you really measuring against? Because this makes a big difference in terms of what you actually want to optimize in the treatment. So, but you know, the potential of this is enormous. Europe is 400 million plus citizens. I mean, if we had, and this is a constant message we get from researchers, industry, and others, if we would be able to put in place, a reliable, good system to really get all this data available in a standardized, coherent way, we would really be in pole position when it comes to research, when it comes to innovation, when it comes to really improving our health systems. We cannot do it at the moment because we are too fragmented. This is not, this is not an issue of Europe versus the member states. It's an issue that the member states could be able to do more if they cooperate using the tools at European level that they have at their disposal.
For the sake of time, one question, short question, maybe, and a short answer, because then we have lunch.
Yes, indeed, for the sake of time, I would like to say lots of things, but thank you so much for your refreshing and encouraging words. I think on behalf of the patient population here, the 20%, I would like to, first of all, say it's absolutely fantastic to be here. We've had a lot to say, and we'll continue to have a lot to say, but to do that, we need to be facilitated to be able to go to such meetings like the workshop you're talking about in Copenhagen. You need patients there, but we haven't all the wherewithal and the means to get to these meetings, and we need to be there. So again, it's a plea on behalf of all the patient representatives here. So it's more a practical and a logistical question. Thank you.
Thank you very much. Maybe, Chris, that's for you.
Just want to make a couple of comments about some of the things that have come up. And we're talking about pain, of course, it's terribly important, and we're talking about research. One of the really disappointing things about research at the moment is it just tends to focus on pain. You've already alluded to that and other speakers about the loss of function. Pain interrupts. And it's what the pain does and how it interrupts that matters very much to patients. Future research has to be done looking at interruption, disability, function, and of course mood, how it makes you feel and what's happening about that. And really, we're having a meeting in London actually in October on research, clinical trials, because clinical trials are defective at the moment in that they only look at pain. That's because it's easier to measure. You get a number and you play with the numbers. Whereas these other things are a bit more difficult. How do we assess disability in different patients? How do we assess mood? These are more difficult numbers to crunch, and the scientists shy away from them. And we've got to go back to looking at those things.
Chris, we have to come back to the question of how could we support, if you get it right, to participate in those workshops, because otherwise your voice will never be heard in these expert workshops. For instance, in Copenhagen, for instance.
They can come to Copenhagen. They can participate.
But they said, is there any way to support them financially, because not everybody can afford to come to Copenhagen? We have to think about that, but we have to give them the possibility, not only just invite them. Do I get you right? Not only the invitation is one thing, but you have to practically be able to really come there.